programme for the NHS in England. My name is Mark Ellis, and in my left-hand corner is my friend and colleague Andy Aldridge, and together with Lizelle and Sharon Scott, we make up the planning and design team for A16. But before we start the meeting, I'd like just to hand over to Andy, who's going to go through some housekeeping. Thanks, Andy.
Just a couple of points from me then, a couple of polite requests really. We've got quite a lot of information to impart during the meeting, and we obviously want to stay to time and finish on time. If we could ask for any questions, it'd be really helpful if people could post in the chat box throughout the meeting. What we've then got at the end is a 10-minute session, Q&A session, which Helen Bennett will be chairing, which will give people an opportunity to ask further questions, and we can go through the chat box. What we'll also do with that information is produce an FAQ sheet, which we'll distribute around all of the organisations as well. So we'll cover the questions. And then one final point, Mark's as he goes through, will explain that the IM associated with your organisation will be in touch within the next 5 days. So further opportunities to ask. That's it from me, Mark.
Thanks, Andy. Kate was going to manage the admissions this morning, so as colleagues join us, but this presentation will be available after the event, and we will post this on our Futures platform. Just to go through the agenda, the Alliance 16 programme is actually born out of the Reducing In-Hospital Length of Stay programme for NHS England and Improvement, and I'm delighted to welcome Amanda Howard, who leads that programme, just to share with us a few thoughts at the beginning. We're then going to move on to just some background around the structure of the programme and how we've got this far. And then we're going to go on to what in effect are the strands of our vision, really, our original vision for the programme, in that the programme is going to be clinically led, data-driven and co-designed with those delivering the service. So we're going to hear a few thoughts from Tim Gillett, our Senior Improvement Manager in ECIST, who's going to share some thoughts around networks and the power of collaboration. We're then going to hear from our head of emergency care improvement, Pete Gordon and Nick Holding, and they're going to take us through a session, an interactive session, and actually put you in the driving seat and in terms of how we design the programme going forward. And we're also going to hear from the wonderful Chris Green, who's going to share some of the ambition for how we're going to be using information in the programme. And then myself and Andy are just going to close. But as Andy mentioned, we're going to have a short kind of plenary session towards the end as well. So without further ado, I'd like to hand over to Amanda, who is my friend and countryman. Amanda, welcome, and over to you.
Thank you, Mark. So yes, my name's Amanda Howard. I'm the National Head of the Reducing In-Hospital Length of Stay programme. Just to give a little bit of background in terms of myself, I've been in this national role now for fastly approaching 3 years in May. Prior to that, I spent 20 years of my NHS career in various different operational management and director roles. So I just wanted to impart that because I understand how challenging some of this stuff can be when you're actually in the service on the front line, dealing with extreme pressures. And my God, hasn't it been a year in terms of pressures? And I just want to share with colleagues, and we have over 80 wonderful colleagues on this call with a huge array of expertise and knowledge, which is just so very exciting in terms of starting this piece of work and launching it. I just want to share a quote with colleagues that has resonated with me so much over the past 12 months in particular, and just for me creates that link in terms of trying to undertake significant service improvement and transformation on a background of extreme operational pressures. And that quote is that life isn't about waiting for the storm to pass, it's about learning how to dance in the rain. And my God, haven't we danced over the past 12 months? And my God, it's been some storm. And I think that just describes how we're going to work going forward. That operational pressure is still very much with us. Although it's residing now in terms of the most recent peak, we still find ourselves under significant pressure. And the need to ensure that we're reducing patients in hospital stay is more important than ever, not only to ensure that we've got the right capacity to be able to look after our patients that need to come into hospital, but also to ensure that we're not exposing our population to any unnecessary risks in terms of infection. So This work is just so very important and so very close to my heart, really, because as I say, I spent 20 years trying to do the damn stuff myself, and it's challenging. And I think what is delightful about this piece of work is there is so much knowledge and expertise available through the Alliance, that it will ensure that we have as smooth a ride as it can possibly be. And there will be challenges along the way, and we will learn from them, and we will adapt, and we will become more agile in relation to that. So I just think it's phenomenal in terms of over 80 people dialing into the call with a commitment, a desire and the motivation to make improvements. And the really important things in relation to this Alliance is the fact, as you've described, clinically led is fundamental to what we're trying to do. As managers, directors, national role, we don't have all of the answers. Our role is to facilitate and draw out that knowledge and expertise from our clinical colleagues across the piece in terms of our multidisciplinary team. So I feel when I reflect on my operational years in the service, I did my absolute best work when I was working with a bunch of really infused, motivated clinicians that want to make a difference to our patients. The data-driven bit is again just so important, and I know Chris is going to talk more about this later, and he is the font of all knowledge in relation to our data improvement and a huge array of data that is available to us. And how do we strip that back to ensure that we're actually using the right data and the right measurements to ensure that we're seeing that improvement through the data? It's really important to measure what we're doing. So I think that allows us to have some really, I mean, we all love data, don't we, in the NHS, and it allows us to have those really data-driven conversations that see the improvement come through that data stream, which is great. And co-designed with those delivering the service. So when I came into the national role, I really internally struggled with the kind of the contribution that I could make at a national level. And certainly when you're on the ground and you're in the service, you start to see some of the effects in terms of applying improvement methodology and trying to change and improve services for patients and our workforce. So we don't want to dictate to people what we think is the answer to their solutions. We want to guide them and take a coaching approach to extracting all of that knowledge. So co-designing the areas improvement for the organisations on the call today in relation to ensuring that we all contribute, we all impart our knowledge and expertise, and we all own it, actually, because again, that's really important. As I say, there will be challenging times along the way. The important thing is to support each other, learn from each other, network, recognise that everybody has got a fantastic contribution to make to this Alliance, and really draw on that experience. So I think that's all I want to say at this moment in time, but just to say hello to everybody so that they can put a face to the name. I mean, I've done very little in terms of the designing of this. Mark and colleagues, as mentioned at the start of the call, have done all of the groundwork. I think I've just put my hand in my pocket and got my purse out, really, but I'm really happy that I can do that to support some of this work. And colleagues on the call, if you do want to make contact around any of the national policy or what we're doing at a national level to ensure that we bring the UEC and the discharge wide agenda together, then please do don't hesitate to contact me, and we can have a conversation around that. So welcome, thank you. This is just so exciting, and I'm really looking forward to working with everybody.
Thanks, Amanda. So when myself and Andy were asked to consider the programme and we got our heads together, we wanted to design something that was fundamentally different to what had gone before. And I know there's a legacy of improvement programmes within the NHS, but we wanted something to feel different, particularly coming out of the national emergency. So as Amanda's alluded to, we wanted to develop something that was clinically led. We wanted to develop a clinically led network of good practice and a unified purpose. We wanted it to be data driven, but not simply in terms of performance, but also in the way people use information. And we wanted to co-design it with those actually delivering the service. So what we've come up with is a structured, four-stage structured and staged approach that involves a discovery period, an action period, an evaluation and a graduation. And we'll come to talk about that very shortly. So during the next 6 months, what can Alliance partners expect? You will get remote and on-site support from ECIST and its clinical associates. We have an increasing cadre of wonderful clinical associates that come from many disciplines, and we're hoping to draw those into this work. Over the next 6 months, we'll also be running a series of webinars, action learning sets, and bringing in some presentation from subject matter experts as we go along the programme. And as Amanda's alluded to, she's very kindly opened her purse, and we are now giving an allocation of £31,000 to each Alliance partner, and that's specifically for clinical backfill, for the use of project management or data. So we'll come on to talk about how we would suggest that organisations would use that funding. So in terms of our objectives, we wanted to network a group of hospitals, 16 hospitals across the country, in a unified purpose. And the unified purpose is, firstly, to improve patient outcomes, but also to reduce in-hospital length of stay. We wanted to empower the front line and the back office to make changes, because we recognise that the whole NHS has to work to this agenda, and without both the front line and the back office, we can't make these improvements work. And we wanted to provide targeted improvement support through the rapid application of good practice in each hospital. We've learned, I say, in the last decade through ECIST, there are fundamental things that we know if we have in place, we can really make demonstrable improvements to patient flow. So the criteria for entry to the Alliance, we went out last year in December and asked the 7 regional teams to nominate organisations they felt would be receptive to this programme, but also have the capacity and capability to respond in an agile way. So we asked for executive sponsorship, we asked for a name, managerial and clinical lead. Obviously, they're supported by the regional team, but we wanted organisations that were committed to providing some project and improvement management at hospital level, and obviously the informatics. So by sheer virtue of you being here today, these are the criteria that you met for entry to the Alliance. So just something about our value and commitments. We were hoping that we would, with organisations, would commit the managerial time and clinical resource to undertake the programme. We recognise that it's been an incredibly difficult time, but some commitment to freeing up resource was pretty much pivotal to the success. We wanted Alliance partners to commit to sharing any good practice across the Alliance over the 6-month period, and also publish work as undertaken as part of the Alliance around reducing in-hospital length of stay. So in terms of the timeline, excuse me, we've had nominations towards the end of last year. We're having the launch event today, and we're now embarking on what we regard as the discovery stage of the programme. This will involve our improvement managers meeting with organisations and working through a data-driven conversation where we will look to consider a menu of options of improvement support. And we'll look to go through a formal evaluation in October, and that will be led by our clinical associate, Dr. Liz Deutsch. So these are the 4 stages to the programme. As I mentioned, we're in the discovery stage now. We'll move quickly into action from this point, and the evaluation in October. We've noticed actually by doing this, we have an opportunity for organisations to graduate, because one of our ambitions for this is to possibly move on to a second cohort in October, but obviously that will be subject to an evaluation and subject to what's worked well and what hasn't worked so well. So we're taking a very thoughtful approach to this. So in terms of the improvement conversations, the clinical conversations, as we're calling them, these will be based around a menu of improvement support that we know actually will help demonstrably improve inpatient length of stay. These are very much built into the D2A, the discharge to assess work, and these are the more in-hospital areas of improvement. So in this programme, I think it's fair to say that in terms of the discharge to assess pathways 0 to 3, we know that 50% of patients over 65 can be discharged from hospital without a modest level of support. 45% can go into a community service, and the remaining percentage can actually go into a bedded system. But actually this program is very much around that pathway 0 and pathway 0 to 1, so in hospital length of stay. And these are the areas we'll be discussing with organisations, but these aren't exhaustive. There may be areas you would rather focus on. You are in the driving seat. You may feel a focus on informatics means more to you, and obviously that will be part of the conversation. We're hoping to complete those conversations with each organisation by the end of April. So we've recruited and allocated an improvement manager to each of the hospitals that you can see there. And each of these improvement managers will now be making contact over the next 5 days with you as an alliance partner to actually set up that conversation. So without further ado, I'm going to hand over to our Senior Improvement Manager, Tim Gillett, who is going to share with us his thoughts on networks. Thank you, Tim.
Thanks, Mark. Morning, everybody. I'm just about to share my screen, hopefully. Bear with me a second. Mark, will you tell me when that appears?
Yeah. And we're live. Thanks, Tim.
Is it in slideshow mode, Mark?
No, yeah, we're in slideshow. Thank you, Tim.
Brilliant. Thanks, Mark. Thanks, everyone. That's always a relief, isn't it, when the tech works? Yeah, so my name's Tim Gillett. I'm a Senior Improvement Manager with ECIST, and it's great to see so many people I've worked with through my ECIST work and before that on the call today, and I'm really looking forward to being part of this programme. My background is nursing. I nursed for a few years, then moved into general management roles and was previously a Deputy Director of Ops in an integrated trust in the north of England prior to joining ECIST about 5 years ago. And I just want to share a few reflections really on networks and collaboration, because I suppose one of the things you may be asking is what's different? What's different about this approach, and how will this work? And we've had some experience, quite a considerable amount of experience now of working in a collaborative kind of way. There's all sorts of kind of technical guidance and programs around collaboratives that many colleagues, people like Mark, I know you've been involved in things like the IHI approach to collaboratives. And we've learned a lot on the job around how we do these things as well. And as Amanda touched on, the last year has been amazing, hasn't it? In lots of ways. I mean, in terms of clinically, the way trusts work. And I'm sure that when you look back, as I'm sure you're doing now, at the journeys that you've been on in terms of the clinical provision of services that you've done over the last year and the changes that you've made, it's remarkable, isn't it, to think what you've achieved, which perhaps none of us would have imagined was possible this time last year. So that pace of change has really had to increase as a response to COVID-19 and the pandemic. And you have done things that none of us would have thought possible around ITU capacity, the discharge policy, how flow works in the organisation, and really how everybody comes together to deliver change in the ultimate challenge situation. And certainly within ECIST, we've had to change our way of working too. So previously, our model was very much being on site, working with clinical teams, working with systems to deliver improvement pathways, improvement journeys, and we would typically be on site at least 2 or 3 days a week, maybe more at different times. And I think I'm just reflecting back. I think I've been on site 2 or 3 days in the last year, and the rest of it has been delivered through media, through this kind of a setting. And just to reflect, today we have over 100 people on this call today, with no travel costs, just an hour out of your time. If we were running this 2 years ago, we'd have all probably had to travel to London, realistically. The cost would have been immense, and this would have taken a full day out of diaries for people. But this is just an hour and a half, and it means you're free to get on with the rest of your day, and you can do this at your desk. So we were already starting to think about the power of connection and the power of collaboration before this, but certainly our thoughts have been sped up through this process. And I just wanted to touch back on this slide. This is a slide that NHS has been around for a while through NHS Horizons. It's some of their work that they use on their School for Change agents. And talks on the left there, many of you have seen this, about the dominant or traditional approach, which is around the power to change through hierarchy, through mission and vision, through rational arguments, and it being leadership and top-down driven change, tried and tested based on experience, and being quite transactional. But I think we've already been moving towards towards a different way of leading change, which is through connection and shared purpose. You'll be familiar with, many of you, the work of Simon Sinek and starting with why, and really starting to make that emotional connection. So we're not just connecting with the logical side, but we're connecting with the people's why and why people come to work, and really starting to move in that direction, and really generating a viral creativity. So everybody's able to create, and then it creates more connections, and the connections kind of multiply exponentially. And that involves things like open approaches and sharing ideas and data and co-creating change and really developing relationships. And we think this is the way of the future. This is the garlic bread and the way of the future. We really, and we think that the Alliance 16 programme can really help with this, despite the fact, or maybe even because of the fact, that it will be delivered remotely. So how do we make connections these days? How is it that we've got trusts here from the north of England, from Leeds, from the northwest, through the Midlands, through London, down to the southeast and the southwest, all on a call together, able to communicate together? And tech and the emergence of tech really is the way of doing this. As I said, we wouldn't have been able to do this, wouldn't have thought of doing this 2 years ago. And there's lots of different ways that we're able to make connections. And I just want to give a couple of examples really to fuel your thoughts. Through our work in ECIST, one of my passions has always been clinical site management. So, the bed managers who go around counting the beds, making flow happen, making the discharges happen, and often the glue that hold organisations together. But through my work with ECIST and previous to that of managing a site management team, it was always very much siloed and head down, getting on with solving today's problem. And actually, you'd come in with the same problem every day and solve it in a slightly different way. And it would all be very specific to that individual hospital, that individual organisation. But actually, something that really struck me was that in 140, 150 hospitals up and down the country, people would do, a group of committed, intelligent, bright leaders were doing exactly the same thing every day, but very much based on their own organisation. So I tentatively put out a tweet about 6 months ago suggesting a WhatsApp group for clinical site managers and asking people if they wanted to join that. And within 3 weeks, we'd got over 50 people on it. We've now got 140 people on that group, representing pretty much, I would think, every hospital, every organisation in the country. If you want to join it and you're not on it and your trust isn't represented, do get in touch with me. But the power of that is we've kind of sat back and not really done anything. We've just created an opportunity for connection. And that group is kind of self-servicing. It thrives. There's bits of quiet time. Sometimes, people put a request for information. Somebody did that the other day, a request for information about validation and validation policies. And within 3 years, they've got 10 policies and SOPs for validation from up and down the country. And that is just so powerful, isn't it? And the amount of time that saves, the amount of sharing, and the policy that they will have written, I guess, on the back of that would have been better than if they'd sat in a darkened room in their own hospital with a blank piece of paper starting. So you get some consistency, you reduce variation, all the things improve as we want, but actually we're spreading, we're sharing, we're networking. Sometimes people just put on, is everyone having as bad a day as I am today? And actually that's good enough to get a, yes, it's tough here too. That peer support is really, really important. So there's all sorts of opportunities here to network in a really informal way that is about people starting to share what they're doing. And another thing that we've learned through this is, and some of the trusts on here, particularly the ones from the north, I know Mid Cheshire are on, and East Lancs, and Mid Yorks and Leeds. I think all those trusts were involved in our Safer Patient Flow Bundle collaborative that we ran 2 or 3 years ago across the north. And we entered that in a proper collaborative approach, and we had lots of great presentations, and you need to do this, you need to do that. But we observed and learned really quickly that our position as ECIST needs to be one of facilitation and one of humility. In that, although the presentations, I'm sure, were very, very good and the work they generated was very good, the true power that we observed emerging was around networking. So we put in something that we thought was just a little bit of a sideshow, if I'm being really honest, which was about peer review. So we encouraged and paired up organisations to go and review each other's safer ward and board rounds. We thought that'd just be interesting, get people out. But actually, that was the most powerful part of the whole experience, in that teams were able to go and see how other areas did ward rounds, and were able to reflect back, were able to give them feedback. But actually, the power, it wasn't just with the people who were reviewing the board, who were being reviewed and getting feedback. It was the power that the reviewers got, because they could then take without fail, they could take good practice from this organisation they'd reviewed back to their own organisation. And that quickly became a far more significant and far more important part of that collaborative. So the power of peer review is really, really important. It's something that we really think we can make a difference with. So how do we do that? And this is my last slide. There's all sorts of ways, aren't there? And there are traditional ways of social media. So we could facilitate WhatsApp groups here. If the Alliance 16 wanted a WhatsApp group where you can share stuff that you're doing, pose questions in a really, really informal way, we could do that. We can use Twitter. And not knowing that everybody uses Twitter, but it is a great medium for getting out messages and sharing the journey and sharing success. So we can use Twitter, and we can create hashtags for that. So question for you, what kind of hashtag would you want for this? Is there a simple hashtag we could use where people can share their experiences on the Alliance 16 journey, so we can then search and everyone can collect and collate that? We can use Teams, and clearly for the events that we're going to be doing, we'll be using Teams, but Teams is far more than just the events. There are chat functions in there. There's the ability to upload documents, to share policies, to share local presentations. And we can use the NHS Futures platform. There will be others, but certainly NHS Futures, ECIST has got a strong presence on there now, and most of the regions have also got UEC areas within the NHS Futures platform. If you're not currently on Futures, or you want to get to connect with the ECIST content on there, we can share that too. And as Mark said, the presentations from today and all the presentations, I'm sure Mark throughout the process will end up on Futures. We have lots of things on YouTube as well. We've got a YouTube channel where we share good practice. We're currently doing a bite-sized podcast series. So there's lots, and we'd be happy to do podcasts, video podcasts from any of the systems as you work through the challenges that you're doing, as you do the improvement journey, so we can share some of that stuff. So I really just wanted to kind of maybe open your eyes to some further consideration of how we network and create the energy for change in this, and really share across the Alliance 16 and are responsive to things that you need. ECIST, like I say, as a team, will facilitate what you need. You just need to come to us and let us know what might help. Few thoughts there, Mark. Back to you.
Brilliant. Thank you, Tim. That was really, really helpful. So I think in moving on to our next session, I'm going to ask Nick to share his screen. Our next session is going to be led by our Head of Emergency Care Improvement, Pete Gordon, and Nick Holding, who is an Improvement Manager at ECIST. So over to you, gentlemen. Thank you.
Yeah, thanks, Mark. And hello, everybody. My name's Pete Gordon. I'm Head of Emergency Care Improvement with ECIST, as Mark said, and I'm joined by my colleague and friend, Nick Holding, who's an ECIST Improvement Manager. So this next session is really interactive. Now, for those of you who are not great with tech, what I would say to you, neither am I, don't worry. The purpose of this session is to make it as interactive as possible and to pull out from you guys what's helpful, and as important, what's not helpful. So I'm going to get Nick to briefly talk through how we use Slido. Over to you, Nick.
Thanks, Pete. So you can access Slido by either using your browser or using the slido.com, or if you hold your camera up to the QR code, it will take you to the link as well, and it will automatically upload that for you. Use the login code 9477 to get access to that. So it might not show anything just yet because I haven't started the poll, but you should be able to see the first question should come up on your browser or phone now. You've still got the QR code and the login code on the left hand side as well. We're just looking for your input. As Tim said, and I think Mark said earlier, there's over 100 people on the call today. This is about really getting your feedback on what you want from the programme. It's really important to get your views. So the first question is, what are your hopes and aspirations for this programme? You've come into this some of you may be fully informed, some of you may be a little bit uncertain of what the programme is. What's your thoughts? What do you want to get out of it? So we spend about 30 seconds, a minute now, just collating your thoughts in this now.
Brilliant. So over to you guys, and as you enter the information onto Slido, we'll see all your thoughts coming up on the screen. Improvement for patients, networking, getting flow right, reducing length of stay. The improvement for patients seems to be a dominant one. Earlier discharge, building networks. Wow, it's difficult to keep up. Right patients in the right place. That it will make a difference. To become a better manager. Sharing and learning from others, peer support, which is great because that's one of the big aims of this programme, to connect people together across the country.
So we've got 47 responses so far, 49. Great. So we've got half of the people who've responded so far. So get involved. Yeah.
And Katie, I can see in the Katie Jackson, I can see in the chat box you have an IT issues. You can just put, if you've got a comment, you can just put it in the chat if you want, if you can't get onto Slido. Re-energize myself. Yeah. Opportunity to learn.
So the ones that are really jumping out beyond their own, a big point about improving for patients, sharing and learning, right patients, put that patient experience. There's lots of great comments there. So let that run for a few more seconds now, another 10 seconds just to get some more comments in. But that's really good feedback. I think we're slightly ahead of time, Mark, aren't we, on this one? So we'll give people a bit more time if that's okay.
Yeah, that's fine, Nick.
And we'll be using the feedback and all the answers to these questions to shape the programme, as Mark and Andy and Amanda said at the beginning. So this is going to be, we're really determined that this is going to be a programme that is influenced by people doing the job. And as Tim said, we've learned in the past that, ourselves, ECIST and Amanda's team, we're the facilitators in the background. Okay, next question, Nick.
Yeah, so moving on, we also want to hear about what are your fears and concerns as well. So, it's not all about positive stuff, not all about happy clappy. There's going to be some worries in there. We want to understand that. What are your fears and concerns around this programme too? So, again, same as last time, put your thoughts in there. This is really going to inform us now and will help us moving forward. Lots a bit there about knowledge, sustainability jumps out massively. Yeah, that's a big one, isn't it?
Yeah, definitely sustainability, and I like the one another white elephant. I think that's what I'd have put down. So we're determined it won't be another white elephant. Lack of buying on the ground, getting everybody on board needs to be different. Yeah, agree with that. Time to do it. Happy workforce. Time. Repetitive, needs to be different. Cultural issues as barriers. Same approach, different title.
Those three there that jump out, I mean, they're so fundamental, aren't they? To the sustainability is based on getting the engagement in the organisation in the first place. It's really something to think about, for us to think about, and for you guys to think about. And one of the things that we will touch on as we move forward is that we're not. This is not a race to get started. It's really important to do the background work first to embed this work. So it's how you go back to your organisations and start to think about how you engage people and start to set the scene for this work as well. There's lots of good stuff there. Talking shop, yeah, another really good point there about just becomes another talking shop.
It needs to have clinical engagement. It's so important that this programme makes sense to frontline clinicians.
That change fatigue is a really good point. Now that's going to come up quite a bit. I mean, I think we all felt an element of change fatigue even pre-COVID, and obviously the last 12 months has seen a escalation in that. So it's a really good point to be mindful of that.
Maybe we'll ask a few questions about how do we get buy-in towards the end of this session.
So a few more seconds just to let that run for a bit. I think sustainability is definitely the big one, isn't it? And embedding.
Yeah, definitely.
And again, as we mentioned previously, any comments around this, please put them in the chat box as well if you feel you want to make any further comments on what you've identified in the word cloud. Okay, so I think we got about 56 people again from last time. So moving things on, last few seconds, moving things on again to the next question. So based on the indicative menu of support, which is absolutely not exhaustive at all, where do you think your focus will be as an organisation? Choose 3 where you think we won't hold you to it. This is just to get a feel for where you as organisations feel will be leading towards in the areas of support.
And there is an option for other. So as Nick said, this is only indicative.
To really appreciate as many contributions on this one as possible, please.
So top 3 at the moment: improving time of discharge, criteria-led discharge, criteria to reside, board rounds. That's the top 4 actually. Need to count.
So we've got a less enthusiasm around frailty and parenting. Okay, so again, this is not to tie you to anything. So this is just a sort of indicative at the moment.
Yeah, and so there's a comment in the chat box by Anna. What do you mean by criteria to reside? We'll come back to that comment, Anna, and I'll just put Jyoti Nipani, just give her a bit of a warning. We just ask her to comment at the end of this session about criteria to reside. So Jyoti's the National Reducing In-Hospital Length of Stay lead, and she's also an ECIST clinical director. So just have you on standby in about 10 or 15 minutes, Jyoti, to talk through criteria to reside briefly.
So this is really helpful. I think
really helpful.
The focus around criteria. I mean, criteria-led discharge is such a widely referenced term, but there's still some enthusiasm around that. I don't think it's been really nailed properly. So this is good.
And I'm not surprised about improving time of discharge as well, Nick, because this is an absolute passion of mine, and having experienced it recently with a very elderly relative, and it's one which we could definitely improve upon.
Yeah, absolutely. Yeah, we know shifting that curve makes a massive difference.
Yeah.
So see what we've just scrolled down slightly. So we've got here.
Yeah.
Fortunately, we've got no others. So
okay.
we've kind of got a good sense there. So 52 responses. Yeah, that's good. We've got that. So I'm going to move us on. Again, as I say, we're not tying you to anything on this one, so this is just helpful to understand where we're all at the moment. So the next question, these are quite open, really. Now the next 2 questions are really quite open. We really need your honesty on these next 2 questions, and you can be as blunt and as honest as you feel you can be. What ECIST support would you find helpful? Let's talk about what would you find helpful first. We'll come on to what you don't want in a minute. What you need from us. This is your program. We're here to support you and to facilitate this. Really important you let us know where you feel we would be helpful in that. Lots of
critical friends.
critical friends, yeah, sharing good practice is good.
Facilitating networking. Constructive challenge.
It's good practice. Examples of good sharing good practices. Positive, yeah, that's good. Yeah, lots of networking comments. So picking up on Tim's session previously, we can. There's a question in a minute about that as well. So we'll pick up on that. Support with regulators. Okay. Another critical friend. That's good. Yeah.
Voice of reason.
A few more seconds on this one. If we could, we've got 38 comments so far. This is really helpful from our perspective. This will feed into a lot of the conversations we have. One of the things
data, and we've got the brilliant Chris Green speaking later about information, getting that in the hands of the many. Clinical decision making. Sorry, Nick.
I was going to say one of the things that I think Tim touched on and Mark touched on before about the definition of collaboration and collaboratives. And actually, are we always collaborative or are we more coercive? Have we identified the solution before we've even started and then get people to sort of come along? This feels different in that we haven't set out with a preset idea of what we're trying to achieve, and I think these sort of comments are really helpful. Okay, so big one.
I was just going to say, just to tell everyone, we'll summarise these. We'll put them into a slide deck, which Mark and the team will send out, so everybody can see. So we'll be sharing everything. I was just going to say as well, Nick, is the brilliant Rebecca Pulford, who I haven't seen for a few years, also talked about embracing risk and enabling choice. Will follow and included in criteria to reside, but also John Scott mentioned the modern ward round guidance, and I think we've got one of our clinical directors on the call, Andrew Rochford. So I might just bring him in briefly after Jyoti, because we've got time, Mark and Andy, just to talk about that briefly at the end of this session.
Okay, brilliant. So a bit more of a different question on this one. What do you not need from ECIST? And then this is where we need your honesty. So what's not going to be helpful for you? Because we can have preconceived ideas of what we think you might need. But it's important to understand both from what you do think you need, but also what don't you need from us that you feel is unhelpful. Teaching grandparents to suck eggs, yeah, really good point.
Yeah. Unrealistic deadlines, pointless meetings, yeah, one of my pet hates, yeah. Repetitive data. Lots of reporting. Yeah. More of the same. Setting unachievables. Well, we'll commit to, you'll be setting what you're out to achieve. We won't be doing that. So death by PowerPoint, yeah, completely agree with that one.
And there's a bit of honesty as this progresses through the programme. In that, if you feel like the bit there about teaching us to suck eggs and telling us the basics, sometimes we may share good practice, which we may see as good practice, but you may see as that's just the basics. So a bit of honest feedback to us as we progress through the programme will be helpful as well. I shared some work around the modern ward round programme recently, and a bit of feedback that I got was, well, that's just common sense. And I said, well, sometimes common sense isn't always that common. So some people may see things as good practice and new and different. Others may see it as teaching us the basics. So please do keep that feedback coming. Taking more than you give. That's a really good one.
Yeah.
I think we have to be authentic in this. We're saying this is your program. We're here to support you. But if you ever feel like this is more about us than you, then we're obviously getting it wrong. Okay, a few more seconds on this one, then we'll move to the last question, I think. Yeah, last question. Okay. Two strict out. That's a good last one there. The two strict outcome is a really good one, because I think Mark will probably be doing this about what the outcomes look like in the end will be your outcomes. I don't think we have a predefined idea around that, and the research we talked about that we're going to work with Liz Deutsch on will help you understand what your outcomes look like. Okay, so I'm going to move us on to the last question, and Tim touched on it before. Having thought about Tim's session and those questions he posed, or any other ideas, how would you like to interact with the rest of the Alliance 16 organisations? What kind of network would you find helpful for us to create for you, or for you to create yourself?
Teams platform, WhatsApp group. WhatsApp group seems really popular, and the one that Tim set up, he talked about earlier on, is so practical and simple. I think one of the things here, Mark, is getting everybody's details. If they're happy to share their mobile numbers, let's get that set up as soon as possible. So, you know, if we commit to getting that set up by early next week, would that be okay, Mark?
The optional catch-ups are a good one. Andy's going to come on to later on the session about a number of webinars or the sessions that we'll put on again, which are totally optional. They're not mandatory, but just opportunities for us to drop in and catch up with each other as well.
Yeah.
Coffee catch-ups on Teams, yeah, it's a really good one.
Catch-up sessions optional, yeah. So nothing's forced here, guys.
Face-to-face human contact, big fan. You know, I don't think we can go too far along the route of virtual work. We have to also think about as humans, we are social creatures. So we think about how we maintain that as well. And maybe there's an opportunity, as you say, when it's safe, that we can come together as well. Regional interactions, yeah, good. Keeping it local as well. Maybe something in that peer support that Tim mentioned in the safe collaborative, how you naturally may link up with other organisations anyway.
Brilliant.
Okay, so I think that's the last question. Yeah. I think we've got some really great feedback there. Pete, do you want to just bring us home on this one?
Yeah, so thanks everybody for that. This is really more powerful than you think, and what's great for us is we're not surprised by those reactions. So thank you for that, and then we'll send those out, Mark, shortly. Just before we move on to the next session, which is the marvellous and mighty Chris Green talking about information, there was a couple of comments. One was about criteria to reside. So Jyoti just probably got about a minute about criteria to reside, briefly what it is, and then also where can people read more about it. And I know that there was a good webinar in the East of England earlier this week. So over to Jyoti.
Thank you, Pete, and good morning, everybody. It's echoing for some reason. Okay, yeah, it's gone now. So criteria to reside basically is a tool to identify patients who can be cared for outside an acute hospital bed. Now, why do we need that? Why do we need to make sure we can care for patients outside an acute hospital bed? Because hospital beds and patient time is really precious resources, and patients don't really want to spend time in an acute hospital bed. Once you go through the tool, which is there in the discharge policy quite elaborately, it talks about 4 reasons patients have to reside in the hospital: physiology, treatment, recovery from a procedure, or functional deterioration. Now, again, if you look carefully at these 4, the recovery part and the functional part fit very neatly into the physiology part. So you'll really end up with 2 broad reasons why patients need to be in an acute hospital: physiology and treatment. So where there is actually a need for frequent monitoring, not just monitoring, but the need for a timely specialist intervention following the monitoring, which can only be provided in an acute hospital. So you really have to think carefully, and this is where we really want to challenge you in this alliance. Think about why does the patient need to be in the hospital. The second one is treatment. Yes, treatment which cannot be delivered at home or treatment which cannot be delivered as ambulatory. Now, you may not have these things in your organizations where you are yet, but that is where this alliance will really work for you. You can use those barriers for discharge as an excellent improvement opportunity and work on those. So I'll stop there for now, but very briefly, it is an excellent improvement opportunity to work on your barriers.
Brilliant. Thanks, Jyoti. And my colleague Callum posted a link to the criteria to reside a bit earlier in the chat. Callum, would you post that again just so people can see it? It's the link to the webinar and a link to annex, the relevant annex in the discharge guidance. Yeah. Mark and Andy, I know we've only got 2 minutes left, so I'm just going to introduce Andrew Rochford, Dr. Andrew Rochford, who's another one of the ECIST clinical directors, who's just John Scott, who's a well-seasoned Chief Operating Officer, just said it would be useful to, for teams to know about the RCP, RCM ward round guidance, which you personally have been very involved in. So just maybe you could spend a minute or two on that.
Yeah, thanks, Peter. Thanks, everyone, for the full morning. Apologies, I'm clinical the face mask. So I've been involved in the refresh of the modern ward rounds guidance, and I think people have made some comments already, but it isn't rocket science. But what we've identified is that there is a lack of reliability and reproducibility, and arguably it's never been more challenging to have a robust ward round process. It's interesting that more than 50% of respondents felt that was a key part of the Alliance 16. We have teamed up with the RCP and RCN and are co-hosting a IHI-based collaborative with them, which will be launching in early summer. The difference is for this program is that there will be a bottom-up approach. So we're looking at ward-based teams. We'll be engaging at sort of band 5, band 6 nurse level with junior doctors and the chief registrar scheme. The document that was referred to earlier, if someone could put that in the chat box, that'd be great. As a wonderful self-assessment tool, which will form the basis of things. We have 2 strands to the programme. One is an IHI QI methodology, so all participants will join that. But there's also expert panel sessions, and each team, wall-based team, will be aligned with a QI coach and a clinical coach to provide one-to-one support. That's it. Watch this space. We'll promote it heavily. There'll be some podcasts, more details coming out, and we'll be heavily linked with the Alliance 16 work.
Brilliant. Thanks, Andrew. And I'll post the link to the guidance in the chat box soon if nobody else has. And back over to you, Mark. Thank you, Pete, and a special thanks to Jyoti and Andrew for that. So, without further ado, it's over to the mighty Chris Green, who's going to share with us his thoughts around information. Over to you, Chris. Thank you.
Great, thanks, Mark, and good morning, everyone. So, just to pick up on 2 points, Amanda, I don't know much about dancing in the rain. I don't really think I could probably stand up in the rain at the minute with the wind. I don't know what it's like in everyone else's part of the country, but that's the way that goes. And also, there's multiple checks that need to be written regarding the names I've been called, mighty, wonderful, all that different type of stuff. I'm a firm believer that we're only as good as the people we work with, and the team, and I include people like Amanda in that as well, are a fantastic bunch of people, and I'm sure you'll learn much from them as we go through this program. So I'm just going to share my screen. I hope everyone can see that. Here we go. Mark, can you just give me a nod if you can see that?
We've got it now, Chris. Thanks.
Great. Thanks, everyone. So my name's Chris Green. My job title is Head of Information for the Emergency Care Improvement Support Team. And I think an important thing that's been raised over this whole kind of morning session so far is the kind of the interchangeable wording regarding data, information, intelligence. We should try and call it something kind of relatively consistent, and I'm probably going to use the word data more than anything. However, I hope that something that comes over this is the fact that actually it's more about changing data into something which is usable or actionable, and that's really going to be my theme for this morning. So we'll just get cracking into it, and obviously what I often say to people is, whether I'm doing a piece of analytical work or I'm helping people out with demand and capacity work, is that data should only ever report back to you what you are feeling anecdotally. If it differs quite significantly away from what you think and what you're feeling, what you're going through, then there might be something around the data quality or the way in which the data has been extracted. And certainly something that's been happening over the past 12 months is that we've obviously gone through unprecedented times. We've gone through unprecedented times in kind of our social, our private lives, but we've also gone through it in terms of our professional lives as well. And from my perspective, you would imagine that I would be looking at this from a kind of a data point of view, and the NHS data has never seen such variation. You know, it hasn't just happened, it's happened for a reason, and we all know what that reason is, from kind of around about this time last year, where we started to see significant changes in the way in which people live their daily lives and the impact that had on with the NHS as well. And we really saw significant reduction in multiple areas, mainly through attendances, occupied beds, but that led on to certain variation in flow metrics as well. And we'll be talking about outcome metrics, flow metrics, as we go through this presentation, because whereas we saw a negative impact in some areas, we also saw a positive impact in other areas as well. And it's really important to understand about what we expect the outcome of a change to be. So don't just look at a piece of improvement work and kind of say, well, let's just chuck some data, let's just chuck some metrics, hopefully things come out. But it's more about actually what we want to come out of this. So what we're going to look at is we'll look at various metrics to see how this has affected flow through the acute sector, but we'll also have a look at the measurement for improvement methodology as well. And certainly what we've seen over the past few months, probably about the past 12 months, is there has been variation, and obviously we look at it from a provider level, a site level, plus also a regional level and also a national level as well. And I'm going to be showing certain extracts from the ECIST daily UEC dashboard. It comes out every day, as you would expect from a daily dashboard. I know multiple people on this call will already receive a copy of it, but if you'd like to receive a copy, my contact details will be at the end of this, and please feel free to drop me an email. But what we've got over on the left-hand side is we've got the proportion of occupied beds for general and acute, and you can see the real variation that we've got across the whole country. And so the variation in the bar, as you can see, is from 74%. Some organisations, some regions are at 74% bed occupancy, others at 97%. But you can really see how that differs massively. So you've got areas in the West Midlands which are quite high levels of occupancy, but then you've got regions up in the northeast, and then you've got regions down in the southwest where there is quite significant variation. The important reason to look at it like this is that if you looked at data just from a kind of either a data table or as in a really simple run chart, you wouldn't necessarily understand this regional variation. And we've got, as I said, on the left-hand side, overall GNA bed occupancy, and over on the right one, a bit more of a pertinent one, which is the proportion of beds occupied by COVID positive patients. Now, this was taken, I'd stress, this was taken a little while ago, but this was when we certainly saw quite a significant regional split. So when the northwest was under significant pressure, and there was upwards of 27% bed occupancy. Now, I know certain providers will, in each region, will have seen even more variation than that. And I think upwards of around about 40 to 45% of beds occupied was one of the highest levels that I saw of COVID positive patients, which obviously has a massive implication on the running of that provider. But this is just a simple demonstration of how to visualize data in a really good way. And as we're at the start of this process, it's really good to understand what the 7 steps towards measurement for improvement should be. And, you know, I had the joy of working for one of the organisations that's on this programme for around about 8 or 9 years. And I learned a phenomenal amount. And I think people would kind of say of me that I'm not a traditional analyst. I'd like to think I'm not that much of a geek, but my colleagues might beg to differ on that one. But what I kind of wanted to do was really understand what it was that people were trying to do. So I think, you know, all too often the information and analytical staff just sit behind their computers and just, you know, questions get fired at them and they answer them. But I wanted to spend time with people to shadow them, to understand exactly what it is. And through this program, what we want to have a look at is really deciding what it is that we want to accomplish. So step one is around deciding the aim. So what is it that we're going to do? What is the improvement journey that we want to be on? Because then when you understand what your aim is, you can then go around about choosing your measures. And I often use the analogy of the rifle as opposed to the shotgun approach. Okay, so when I used to work at a trust, one of my divisional directors would often ask me, and I would challenge him on this, an ambiguous question. And he would say something like, you know, what is happening around urgent emergency care demand? And the thing is, that's such a generic, ambiguous question that you can't be surprised if the data that is then provided to answer that question is also generic and ambiguous. So therefore, if we understand what it is we're trying to do, we can help define the measures that we want to see. So defining the measures is really important as well. Understanding what the assumptions are around where are we getting the data from, what are we going to include or exclude, because that's really important to understand, and also taking into account data quality. Now, this is a really hot topic at the moment around data quality for multiple different reasons, and it's probably something that, you know, as Jyoti and Amanda were talking around about criteria to reside, is that, you know, that's a relatively new collection, and the depth of information that has provided has been phenomenal. However, at the start of the process, the data quality, I think it's fair to say, was not where we want it to be. However, because we're consistent about the approach, the data quality has got much better, and we are now able to use that data to put actions in place to see an improvement. The next step is then around collecting the data. So we've understood what it is that we want to capture. We've understood the intricacies around trying to extract that data and present it. And then we start to actually analyze it. So really understand exactly what it's showing. Are we expect a situation to get worse before it gets better? And then question 6 and step 7 are all about reviewing the measures, making sure that it's showing exactly what we wanted to show. If it doesn't, then going back to step 3 and 4, defining those measures and looking at how we can take the steps forward. But the kind of the first ones that I often start with is about knowing the basics. You know, Pete, when my first day with the team, I heard Pete give a presentation done on Exeter Racecourse, and the thing that kind of struck me was about the NHS being a complex adaptive system. And I think all too often in the NHS, because we think about the NHS being complex, we often think the solution has to be complex. And what I say to people is actually, don't worry about the complex solution, build up the layers of complexity. And unsurprisingly, and colleagues will definitely back me up on this one, is that I don't share many similarities with Einstein, certainly not my hair or anything like that. But the thing that I do share with him is the quote that he said, which is about everything should be made as simple as possible, not necessarily simpler. So actually, if, for example, the question was something around, say it's to do with SDEC activity or something like that, it's really trying to say, right, the simple starter for 10 is how many patients come through the SDEC environment. Okay, right. We all agree on that number. Right, now, can we take it another step further? Can we then have a look at diagnosis? Can we have a look at the pathways that people are on? Can we have a look at the dispositions of those patients and where they go on to next? So starting off the task simple and building up the layers of complexity is much better than starting off with a complex solution, not understanding it and having to go back to the drawing board to start with. And what that will help you do is it will help you drive the challenges. Okay, so what we're starting to have a look at the data. We've built up the layers of complexity, but it will help you, particularly if you look at things like driver diagrams, it will really help understand exactly the process that you're going through. And the thing that the phrase that I often get frustrated with is when I hear the phrase new and improved. You'll often hear this in terms of technology or things like this, or razors. I often hear it being mentioned on the telly, and I hear that phrase new and improved. Okay, it can't be new and improved, because if it was improved, then it can't be something new, because if it's improved, there was something before it. And if something was new, brand new, it can't be improved upon. So just be really cautious about your phraseology and the terminology that you use around your improvement journey. The important one for me as well is around visualization of data. Now, this does come down to a little bit of personal preference. My old chief exec he had an accountancy background, and so he loved to see data in tables, just numerical tables. Don't necessarily worry about run charts, don't necessarily worry about any other type of visualization. He could spot something just through data tables, and that's fantastic. However, the vast majority of people do like to see some sort of graphic representation of the data that's going through. And I just kind of want to draw your attention to one pitfall around the use of different types of graphs. Now, I've seen every type of graph that is possible to create. Some of my favorites are around about 3D exploding graphs. But for around a measurement for improvement, the one graph you should never use is pie charts. Okay, there's only one good way in which you can use a pie chart, and that is by doing this: the amount of pie that I've eaten and the amount of pie I haven't eaten. Do not use pie charts. The only way that in which something might be done around point prevalence studies is when you are writing reports and you want to say we have improved from X to Y, and there's no problem around doing that, as long as you have supporting evidence, a statistical change in a run chart. So if that has happened, then that is absolutely fine. But just saying your data has gone from X to Y by itself is not necessarily going down the measurement for improvement methodology. So picking up on that point, and once again, this graph at the bottom comes from the daily UEC ECIST dashboard. And you don't necessarily need to worry about what statistical process control is, and we're certainly not going to go through that now on this brief presentation. If you do want to, please feel free to contact me and we can send you out loads of documentation around this. But statistical process control is a way in which we can move away, and this is what I'll come back to earlier, moving from data into intelligence and action. So it automatically will identify what is normal within process variation and what is outside of normal variation. And so what we can see just from this run chart, it's the past 100 days of long stay patients, and this is the number of patients with a length of stay of 7 days or more. You can see that we've got the black line is each individual day. The slightly longer grey dotted line is the mean line, and the grey dotted lines are the upper and lower control levels. It will automatically do this for you, and it will also automatically put in things that are statistically significant. So you can see when the blue dots are a statistically significant positive event. So in this case, it's when the process has, the data has gone low, and the red dots are high statistical variation. It will also give you the ability to put in their improvement change dates. So if you have started a particular piece of improvement work, you can enter a date and it will automatically make those changes for you. The document also starts with the grid, which is a 4x4 data visualization of, over on the left hand side we've got some demand metrics. In the middle, we've got some process metrics, and on the right hand side, we've got some outcome metrics. Now, this grid will do one of two things. It will do point prevalence, but it will also do statistical variation. And so if, for example, in the top left-hand corner, we can have a look at all attendances. And the point prevalence around this is what's happened this week and what is the rolling 6-week average. The reason why that is on there is so that you can just eyeball it to kind of, is it going in the right direction? So, for example, we can have a look at the proportion of patients treated within the first 60 minutes, which is second column, second box down. And we can see it's gone down from the average of 66% down to 61%. But the interesting thing is, so you might kind of say, oh, that's good. Sorry, that's bad. It's gone down. But you'll see the 4 statistical process control rules underneath that. And there are 3 different icons that you'll see on this report. The grey boxes are when no statistically significant variation has been spotted. But you'll also see black circles and green diamonds. A black circle will appear when there has been a statistically significant negative event, and a green diamond will appear when a statistically significant positive event has happened. So what this grid does, as my University Challenge starter for 10 anecdote progresses, is that it will give you the ability to automatically draw your eye to metrics that we might want to pay our attention to. So, for example, if we were having a look, if we were doing a piece of improvement work around patients with a long length of stay of 21 days or more, we can automatically see that there is a positive event. So we could then go and have a look at the SPC time series graph that I showed you on the previous slide to see where that has come from, where it is now, and the improvement that has been made. It will also kind of do exactly the same thing for areas such as occupied beds, and we can certainly see around here that there has been a really significant upward trend of occupied beds. Now, this was going through the kind of the early second phase of the pandemic, particularly going through the last stages of summer, going into autumn, where we started to see significant occupied beds. What you'll also see on the right-hand side is, we've got the black line showing you the occupied beds, but you can also see a grey line, and this will predict what is going to happen, or what the model predicts what it thinks will happen over the next 7 days. So some metrics are predicted, some metrics are not. So demand metrics, for example, occupied beds, long lengths of stay, ED admissions and attendances are predicted. Things that are process metrics, such as time to treatment, 4-hour standard, etc., are not predicted for various different reasons. But also be careful about using statistical process control. There are certain things that you can use SPC for, and there are certain things you can't. So here, for example, because we've got a certain at the start of this particular process, we've got relatively low numbers. But then as it goes through, as I was explaining, into October and into early November, the number of occupied beds occupied by COVID positive patients increased so significantly that actually this type of SPC chart is not the right way to do that. So just saying, let's SPC everything is not the right way to go. You need to understand it. And hopefully there should be somebody within your organisation that does. If they don't, there's a fantastic team led by Sam Riley, who does fantastic presentations on SPC, and I'm sure she would be able to come out to your organisation and go through that. But equally, as we were looking at the whole numbers, obviously at a national and a regional level, they might have a look at kind of one line that says, well, occupied beds have gone up by this, long length of stay has gone up by X. There's real significant variation between providers, and what this is that every grey dot is every provider in the country, and every black dot is for a particular region. I won't tell you which region that is, but this is where, as I was talking about earlier, sometimes you do want to have a look at point prevalence just to kind of understand where everyone has come from in terms of a baseline position. And as long as you use a consistent baseline position, you can do this type of work. However, I'd stress, this is not measurement for improvement. This is point prevalence study. But the reason why I want to show you that is because this is looking back from the past week to where we were this time last year. Slightly a couple of weeks prior, actually, because of we wanted to take a pre-COVID position. And this is kind of showing that on the x-axis, we've got the proportion of beds occupied change. On the y-axis, we've got the long length stay change. And you can really see that we've got trusts over on the far left-hand side of the x-axis that have reduced their beds occupied by 25, 30, even up to 35%. However, there are some organisations that have seen an increase in their overall occupied beds. And there's a myriad of organisational change in there. But what we've also got is the long lengths of stay change as well. So we've got some organisations that have seen huge reductions in their long lengths of stays. I'm talking 50, 55, 60%. But then we've also got organisations such as organisation Lucky Number 13 that have actually seen an increase in their long lengths of stay. So what you need to do is you need to understand exactly what is going on with the metric, but also understand the variation that is contained within.
1 minute, Chris.
No problem. The last aspect of the UEC dashboard is a metric comparison graph. So the one thing that we're great at the NHS is doing is just looking at one metric in isolation. But what we want to be able to do is we want to be able to kind of say, well, hang about, there is this metric over here, and does it have an impact on this metric, and does it have an impact over here? And what we can do is I've put in here the four measures, composite metrics of flow. And so we've got the black axis, the black graph, which is long length of stay, 21 days number. We've got the blue line, which is 4-hour performance. We've got the green line, which is overall beds occupied. And then we've got the red line, which is proportions of time to treatment. Now, what we can see is that our beds occupied, the green line, has started to increase, which is not necessarily a bad thing. But the thing that I'm more interested in is that the rate of change for the patients with a long length of stay of 21 days or more has gone up at a higher rate than our overall occupied beds. And at the same time, we can see that our time to treatment metric has started to decline as well. So really kind of emphasising that impact about flow through the hospital, from the acute wards down to the assessment areas, and how that impacts on the emergency department. So as I said, feel free to email me. My email is chrisgreen@nhs.net. I'm also on Twitter. If anyone has any questions, I think we're going to have a session at the end. So back over to yourself, Mark.
Thank you, Chris. So our next session, as I said, we will be having a short plenary session at the end of this event, but the next session is going to be focused on a series of webinars or live events we plan to run over the next 6 months. So I'll hand over to Andy for that. Andy.
Just let me know when you can see the slides, Mark.
Yep, we're okay.
Does that work?
Yes. Yeah, thank you.
Lovely. Okay, so what I've displayed there is, as Mark's just said, a series of live events that we're planning to run over the period of the Alliance. This is for information. I think in the chat box, Tony had asked if we were going to share the slide set. So we absolutely will be sharing this slide set along with a range of other information early next week. So you will get this information early on. The idea is to put you guys in the driving seat, really, so that you can drive this forwards. The purpose for displaying these now is to give you the heads up on dates and the information, the content of the live events, so that you're prepared for it and you can get dates in diaries for the guys within your organisation, really. So there's 2 slides, as you can see. We're running the range of live events. There's a number of live events, as you can see, around evaluation, and we start with evaluation so that we're preparing as we move through the programme, that we've got the evaluation right towards the end. But as I say, you'll receive these early next week, the whole slide set, but you'll have these dates that you'll be able to get into people's diaries early on. So I'll keep my session short because we want to allow some time at the end for questions. So what I'll do is hand over to Helen Bennett, who's going to take us to the plenary session. So over to you, Helen.
Hi there, thank you everybody, and really thank you for this great session that we've just had. There's been an awful lot of discussion with the Slido session and also in the chat room. I think if I just ask anybody, we've got about 10 minutes, so if anybody wants to, or just there or thereabouts, if anybody wants to actually ask the panel any questions, please do put your hand up. If not, I'm happy to go through the questions that have been already placed in the chat room. So I'll start with that bit first, but as I'm talking, please do put your hands up and I'll try and come over to you. Just the first one, I think, actually, Chris, just because you sort of mostly were doing the last one. I know Jyoti, one of our colleagues, has been chatting in the chat room as well, which is really helpful. Just somebody has asked whether or not you can see the correlation between a lower occupancy and better flow. What's your sort of thoughts on that?
So I'm going to do a classic political answer of yes and no, and the reason for that is because so the data that I demonstrated was taken from the daily UEC SITREP report that every provider has to send in to NHSEI on a daily basis, and that is overall bed occupancy for the whole hospital. And the challenge around that is, and we often describe the hospital as different pace beating hearts, if a hospital, for example, is running at, say, let's say it's 90% overall bed occupancy, but the challenge is that the acute wards are running at a significantly different occupancy rate to the short stay wards and potential issues around SDEC. One doesn't necessarily mean that the other one's going to happen. So actually, when we work with organisations, what we do is we break down bed occupancy by the different areas so that we can look at the flow through the whole emergency floor and the whole pathway as well.
Lovely, thanks, Chris. And I was going to ask Anna's, but she's actually got a hand up. So Anna, do you want to speak to Chris yourself?
It wasn't actually specifically a question for Chris. I'm sorry. I thought we were inviting general questions.
Oh, yeah. No, you are. Sorry, I was just interesting. I was about to ask him your question that you put in the chat room, but go ahead, ask whatever.
Well, let me ask that then, and perhaps you'll permit me a second question. Yeah, Chris, the question is really about whether we can use, what could be quite a powerful network here to build a bit of a movement to influence the powers that be around consistency of reporting. Mm-hmm. Because it's, I've done quite a bit of work with colleagues across different Shelford trusts, at least, and it's helped me to understand that what some people count as medically optimised, other people don't. Long length of stay, some beds are in, some beds are out. Differential interpretation driving differential reported performance. I think we need to get to the bottom of that.
Absolutely, Anna. And I know I've worked closely with Amanda over the past kind of few months as well on exactly that. So there are several processes in place where we consistently have a look at not only the definitions, but equally what is captured. And obviously, over the past kind of 12 months, we'll be the first ones to hold our hands up that we've asked organisations, both community and acute providers, for a lot of different data. What we're currently going through is around what are we using it for? What is the burden on organisations? But can greater efficiencies be obtained from it? But I think that coming back to kind of something I said through my presentation is, what do you do because of that? So if we're just collecting data for just collecting data's sake, then that is entirely hitting a target and missing the point. We should be actioning it and doing something with it. And so actually, I think, having a network of people like this, we can really make a difference through it. So thank you for that point.
Thanks.
Anna, did you want to ask your other question as well? Or you're on mute, sorry.
Sorry, sticky mute. It was in relation to the mechanics of the programme and how we, I think you mentioned at the beginning of the session, there might be some guidance on what the 31k could be spent on and how do we access that, and just any thinking around that aspect of it would be really grateful. Thank you.
Could I answer that, Helen?
Please do, yeah.
Yep. So in answer to your question, Anna, we have allocated 31k to each of the 16 organisations, and that should be in your coffers right now. As far as the expenditure, that will be very much around a standard operating procedure we've developed, and we were hoping that that could be used for clinical backfill, for data analysis, and for project management.
Okay, lovely, thanks. And I think we've got Kate with your hand up next. Do you want to ask any of the panel your question?
Yeah, it was another sort of practical question, really, just to sort of try and understand exactly what the discovery phase would entail, just so that we can sort of be warming colleagues up to that.
Again, so I'm happy to answer that, Helen. And the discovery phase is very much a clinical conversation. So we would anticipate our improvement managers will be in touch with you within 5 working days of this meeting. And we'd like to have a meeting with your executive sponsor, your clinical lead, and we'll also include our improvement manager and our regional clinical director in that conversation. But it'll be a data focused conversation on what actual support we are able to offer and what you feel would be the best type of support.
So sorry, can I ask, the data focused conversation, is that data that we're providing as part of that discussion, or is that data that you're providing, just so I can understand?
Well, I think there's a conversation around obviously 7, 14 and 21 day length of stay, but there are also opportunities there to consider some of the modelling around the D2A pathways. So the 50, 45, 2 and 1. So the John Bolton modelling. So it's not specific in terms of what data we're going to use, but just going to use all of the data surrounding your particular organisation around length of stay. But obviously, Chris is very much instrumental in that discussion as well.
Thank you.
Yeah, Kate, just picking up on your point, I think this programme, there's going to be a balance between data that we already and I think that will be really beneficial, is that obviously we don't want to create a cottage industry around this. So if it's data that we, as in centrally, already have, we can help assist with that in any way, shape or form. However, if it's quite a specific piece of work that you are wanting to have a look at, be more than happy to work with your individual organisations so that we can understand, coming back to the 7-part process that I talked about, we understand what it is you're trying to do, have we got the data, or what are the definitions and assumptions?
Thank you.
Lovely, thank you. So I'll just go back to a couple of comments that came in quite early on with regards to this has been said a couple of times actually. It's a bit of a plea really from organisations and systems just to build on the existing improvement structures that they've got in place. So to add and complement rather in opposed to sort of being done unto, which they're very keen to just sort of add into their improvement programs, which would be I think is really quite reasonable. There's another question or comment really around wanting to work as one system and the project to involve the acutes and the whole system. So sort of starting with one conversation that's involving all. And I think probably we would all agree that actually that it would be the right approach to get the right people in the room at the first point to get the conversation started for everybody.
And Helen, just on that point, so we've had that conversation in another part of the country, and actually it was quite a good conversation, and I think there are some benefits in doing that.
Sure, yeah, absolutely. So really keen. There's a lot of discussion about how sort of this could work in different organisations and how what sort of methods of learning would be useful, and obviously that came up in the Slido as well. But some comments around the networking part and action learning sets and what can be learned together, and how that can help to reframe conversations but come up with solutions. So alongside the comments that went through the Slido stuff, just some real understanding about what works in practical terms and how to share those learnings and have those conversations. And I think Tim spoke about that earlier when he talked about the site management WhatsApp, where you often get that peer-to-peer conversations. It's very, very much what this programme is being led to start initiating. So okay, so those generally are a few bits and pieces that we've just had in. Is there anybody else that would like to put their hand up? We've only probably got time for one question if anybody has got anything else that they'd like to say.
Can I just answer Matthew's question? So just around contact names, that will be in the information that goes out early next week as well. So the dedicated improvement manager allocated to each trust, the trust will know that name early next week. And it'll be part of this pack, Helen.
Lovely, thanks Andy, that's great. Lovely, okay, so I think that's probably it for time-wise as well. So Mark, I'll hand back over to you.
Thank you, Helen. So just before we close the session, I'd like to ask our national clinical lead, Jyothi Napani, to just a few words of inspiration, Jyothi. In 1 minute, if you can. Mark. In 1 minute, if you can. Thank you.
Thank you very much. No, I'm really excited, really overwhelmed. Looking at the attendance, more than 100 at one point. Great, getting everybody together. I really wish to thank you all for making the time to come here, participating in this fantastic alliance going forward. And I really genuinely hope that you will make a difference in your organization in the next 6 months in whatever little way you can, little or big. So thank you all the 16 participating trusts. Thank you, the entire ECIST team. Really made a fantastic program here. Thank you all the regional teams for helping us get the 16 Alliance trusts. And thank you very much to my colleagues in the Reducing In-Hospital Length of Stay team who have really worked very hard behind this program as well. If I can emphasize on just one thing, I really want to pick up on Tim Gillett's point on peer review. I think you will find that is the single most important thing that you might find very useful going forward. Somehow listening to other people coming into your organization and telling you the things which you already know works wonders for some reason. So please use the networking opportunity and the peer review opportunity. Thank you very much.
Thank you, Jyoti. And just to conclude from me, really, and I'd just like to say a really special thank you to all our speakers today for making my job as continuity advisor very, very easy. Thank you so much. It's been great. I'd like to thank everybody on the session today for both their candor, really, in terms of the interactive session, because I think that is incredibly helpful for us as a team, and we'll certainly be acting on that and actually playing that into the co-design. And finally, a sincere thanks to you all for attending today. I think we're at the beginning of a very exciting journey, and one that myself and Andy are really encouraged to see. So on behalf of Andy, Sharon, Lizelle, and myself and the rest of the ECIST team, we wish you well. We look forward to working with you over the next 6 months. Please check out our social media. We're on Twitter, Facebook, and our Futures platform, and we look forward to seeing you very, very soon. Thank you all.
Thank you.
Thank you.